Innovation, imagination, wonder. These are just some of the words used to describe Dr. Harvey Passes. Dr. Passes explores interesting people and ideas that will stimulate you. He questions the people who develop, create, and employ novel concepts in business and everyday lives. He especially loves to speak with successful people. How did they do it? How can you do it too? So let's join Dr. Harvey Passes in his quest of wonder and curiosity as we watch Dr. Harvey Passes Presents.
I have some interesting things to bring to you today. As you know, my love, again, about anything that's Long Island. I've discussed things about the bounty, the food, the wine, the people. The people. I have someone in that category for you to meet today. A Long Islander and someone who is very well accomplished, a specialist, if you will, in an area of focused attention. It's an area that deals with our children, and it's an area which deals with, well, it's close to my heart, children's hearts. And it's an area where, well, there's a number of you watching this right now who have loved ones or yourself who may have this condition. And it has to do with an area in your heart where there isn't any closure and there is an opening. And we're going to discuss that today, and you're going to meet and learn from Dr. Sean Levchuck how this treatment can be accomplished today right here on Long Island, well, in a non-invasive fashion, as opposed to opening up your chest and having it corrected, and why it should be corrected. So without further ado, I want to bring to you Dr. Sean Levchuck. Dr. Levchuck.
Nice to meet you, Dr. Passes.
It's great to have you come down here, and from your very busy schedule, I appreciate you coming down. Let me tell the folks at home a little bit about who you are and why you're a pretty special kind of guy. Dr. Levchuck, he's director of the Pediatric Interventional Cardiac, the teeth don't fit, cardiac program at St. Francis Hospital. He's chairman of pediatrics at St. Francis. So you're doing two very interesting things here. You have a fellowship in pediatric cardiology at St. Christopher's Hospital for Children in Philadelphia. You're also board certified in both pediatrics and pediatric cardiology. You're a busy guy. You've performed over 2,000 interventional procedures in children and adults with congenital heart disease all last Thursday. No, only kidding. Okay, you've done over 800 interseptal occlusion procedures. That's procedures to close up the hole that's in certain areas of the heart. And, well, you're here today to discuss how it was done and how it can be done today. First, what is an atrial septal defect? And talk about it in plain language.
An atrial septal defect is a hole between the two upper chambers of the heart that we were born with.
Okay. And when we're born with that hole, you're supposed to have it when you're born.
Well, some people do. There are some holes that we see at birth, but these generally are bigger holes that should have gone away.
Okay, they should have closed up. Now, I'm going to throw out some fancy terms, and then you're going to use some good old-fashioned everyday language to answer it. What is the term? It's called patent foramen ovale.
A patent foramen ovale is a normal opening that should be present in all living people's hearts within the first 2 years of life. That's an opening that allows for the umbilical cord blood from the baby's mom in utero to circulate throughout the body. But in the first couple of years of life, 4 out of every 5 people will naturally close that hole, and 1 out of every 5 people will have it open.
That's a large number.
Yes.
20% of the people will have the defect remain.
Yes.
Is it dangerous having that defect or not?
It can be. About 1 out of every 10 people that have this defect can have a problem with it sometime in their adult life.
Okay. So now there's two kind of holes here. One is the first one, an atrial septal defect, and
yes.
The other one is a patent foramen ovale. What are the differences between the two?
Well, an atrial septal defect is a real hole. It's literally a hole in the wall between the two chambers. A patent foramen ovale is a flap, a doorway that is left over from neonatal life that hasn't closed yet. So they're very different, mostly in size and location, and especially in symptoms.
Interesting. What are the treatment options for patients who are diagnosed with atrial septal defects?
Well, they were basically...
Traditionally,
the old way was an open heart operation.
Meaning you cut open the chest and you...
Yep. An open heart, opening the chest up, opening the heart up.
It's open heart surgery.
Yeah, and sewing a patch in with a 1-week hospitalization, the pain, the recovery,
wow.
the long rehab.
I would imagine a lot of people, unless they were really forced into doing this, kind of shied away from doing that.
Yes, it's a pretty scary operation.
And what are the treatment options now for, as you call it, PFO, but patent foramen ovale?
The patent foramen ovale in the old days was an operative thing as well. You had to open the chest up, and now, fortunately, we have some nice new things.
How do you know if you have this? I mean, what are the symptoms of the atrial septal defect?
The symptoms of the atrial septal defect can be many. Some children present with heart murmurs. Some children will present with failure to grow. They just won't grow. They're small children. Some children have a lot of frequent respiratory infections. They're often misdiagnosed as having asthma when, in fact, they actually have this hole.
Wow.
And that, in adults, it's a little different. Sometimes it can be completely asymptomatic.
So it's probably a prudent idea when a patient is referred to a specialist, for example, who might take care of children with asthma, for the physician to just check and listen for any kind of murmur.
Yes, absolutely.
Before you go ahead and you treat them.
Long before you want to go ahead.
Yeah, absolutely. That makes really good symptoms. What about the PFO, the patent foramen ovale?
The PFO is an interesting issue because it's really come about since the mid to late 80s. Prior to that, nobody really thought much about PFOs. But in the late 80s, we were seeing a number of adults who had neurologic symptoms, transient ischemic attacks, and strokes that they found no other cause, and then they found that the PFO was the cause of the stroke. And in 2006, the association with migraines and strokes and PFOs have been identified.
No kidding.
Yeah.
Wow. Now, are there tests to help diagnose these things?
The most common test that we generally recommend in a child would be just a regular echocardiogram to diagnose an atrial septal defect. We combine the echocardiogram with an electrocardiogram, which records the electrical activity in the heart, and then we would go from the electrocardiogram to the echocardiogram and hopefully see the limits of this defect.
Is this so people watching this should not be concerned, but how invasive are these tests?
In children, the electrocardiogram and the echocardiogram are completely non-invasive. So there's no pain involved.
No pain, no nothing. The child just say stay still.
Stay still, and that's it.
Okay, and I know that when you do these tests, you run movies and all sorts of distractive things for the kids.
Yeah,
they can watch Shrek or something else.
Absolutely.
Okay, and I know you come in with a clown suit on with a rubber nose, and you do what you can to distract the kids.
Anything I can.
Well, as chairman of Pediatrics, I'm imagining you would do anything with the kids.
We have the Patch Adams routine.
I knew you were going to say the Patch Adams routine. Okay, now what's a I love these words. What's a transcatheter septal defect closure?
Well, that's really what is new and out there in the late 90s, in 99, 2000, we noticed that these devices were now becoming FDA approved that could allow us to go in instead of the traditional open heart way and go in with a catheter that's the size of about a cocktail straw. And this catheter would be advanced through the vein at the corner of the leg, and in that catheter would be loaded a device that would allow us to go in and actually close the hole, the PFO or the ASD, by putting this device through the catheter, taking the catheter out, and then have the patient go home in a couple of hours.
Well, in a couple of hours?
Yes.
They don't have to stay over?
Don't have to stay over.
They're usually pre-medicated, though, with certain medications to prevent any kind of potential bleeding problems or anything like that?
Yes, we do.
Clots?
Yes, we do use aspirin. Sometimes in the older patients, even Plavix or Coumadin, some of the more powerful anticoagulants. But in the children, it's a very nice thing and very innocent thing.
So what I'm hearing right now is that we have a technique that is kinder and gentler and easier on the body than just ripping somebody's chest open.
Absolutely.
And there's got to be a certain degree of morbidity or a certain degree of untoward effects happening more with open heart surgery as opposed to just using transcatheterization.
Absolutely. When you have open heart surgery, the side effects really are multiple. You not only have the side effect of having your chest opened and all the things that go along with open heart surgery, stopping the heart, going on a heart-lung machine, having your heart opened up and having an artificial patch sewn in there, plus all the things that go in with the stitching and all that. Then the prolonged recovery, the 2 to 3 weeks recovery before the pain goes away, the chest tube. It's a wide open thing, and it's a wide open opportunity for different things to happen, plus the overall infection risk of sitting there with your chest open.
So in that particular case, in the traditional approach, the postoperative sequelae is really a factor of just access getting to the heart.
Yes.
Because now, after you just patch it up, the problem isn't with the patch.
It's all the other stuff.
It's all the other stuff to get there.
That's exactly right.
So with this new procedure, you don't have the other stuff.
No other stuff. It's just through the groin, the vein at the corner of the leg, and the patient just go home with a Band-Aid.
With a Band-Aid. Okay, before we discuss some more about this, let's show my friend at home who's watching exactly how you do this. I know you brought some demonstration with you.
I brought two devices that we typically use. The first device I'm going to show is the CardioSeal device, which is made by NMT Medical. It's a double umbrella device. It's a Dacron material held together by a titanium or nitinol wire frame. It's spring-loaded so that much like a...
looks like an umbrella.
It's exactly what it looks like. Much like an umbrella. It has
looks like
two
the umbrella
sides.
you would have in a Mai Tai or something. Really small.
It's a double umbrella, and it simply retracts.
Let's see now. Okay. So in essence, let me see. Where's the defect? Here it is. So let me do this. So let's see. Okay, I'm going to get a close-up, see if my gang can do that here. And so this would be the defect. We're looking at now at a little piece of plastic here, which is acting as, that's good. So you see right over here, there's a line here. And that's going to give us access. And there's a hole, supposedly, in the center over here. So now you thread this. I'll hold my hand over here. Maybe if you can work in this area, Dr. Levchuck.
Sure. The device actually will collapse and fold up.
So it folds up like an umbrella.
Just like an umbrella.
Before it opens, it closes.
Yes.
And now you pull it back.
And I could preload it in here.
Right.
With the catheter across this.
Okay.
The device will literally take shape like that.
Wow, and it just pops right into position.
Open.
That's great.
And what will happen with that is that a skin will grow over that within the first 2 to 3 weeks, and that device will actually become part of the heart.
So all of this white stuff, this white square, this Dacron, is going to stay on one side of the wall of the heart and on the other side of the wall of the heart.
Yes.
And these little metal springs here are going to stay there. And what are they made out of? Titanium?
Nitinol.
Nitinol, okay. And they will stay there and keep it locked into place.
Yes.
And then heart tissue will grow through the white Dacron. The Dacron will act as a matrix.
Yes.
And it'll grow through it. And it really won't be so much that this will act as closure, but the patient's own tissue is going to act as closure.
Yes.
And then this will stay in the patient's heart forever.
Yes.
Fascinating. And then you just take the rest of it out.
The whole catheter, everything comes out.
How do you cut? Do you cut these
sutures? We cut this, and it actually cut this string, and it just pulls right out.
And it just pulls right out.
Pulls right out.
So the entire string just comes out.
Comes right out. It's all connected.
I see. It's all connected here. It comes right out.
Yes.
It doesn't stay in there.
No.
Fascinating. Thank you, guys. Fascinating. Okay, so this material goes in, and it's been done for how long?
There's about 35,000 worldwide implants done all over the world. It's been in use for about 15 years.
15 years. Wow.
But it's really only in this country about 8.
So it's been used in Europe beforehand,
yes.
I'm assuming?
Yes, in Europe, in Germany, and England, and India. All the FDA here really tested everything a lot closer than the foreign competition.
Now, I see you have two types here. You have this one white one made out of Dacron, and then you have this other one here. Let me just...
The next device...
See if we can get a close-up here, gang.
You can see it's more of a double Brillo pad. It's really more shaped like it's a disc, actually.
It's a disc, yeah.
And that's called an Amplatzer device.
Named after?
Kurt Amplatz, who is the inventor of the device.
He's not a doctor.
No, he's an interventional radiologist, actually. And you can see there when you put a little traction on it that it's really a double disc. That device in particular is really designed for the larger holes where there's a real dropout, so that you almost have to plug the hole rather than cover it. The Cardial Seal is designed to cover. The Amplatzer is designed to plug. The insertion procedure is virtually the same, and that also goes in through a small catheter, and it's just basically deployed by that catheter and basically unscrewed and placed into the heart.
So this stretches out all the way?
Yes, it stretches and will fold up in the same size catheter that the Cardial Seal will.
And this will go across the defect, and this center over here, it's like a figure 8. See if I can get a shot of that.
That's exactly right.
It's like a figure 8, and where I have this here, as this goes through the hole, this will go on one side of the hole, this will go on the other side, and when you let go,
and as the disc
it collapses on it.
Yes.
And it plugs.
It plugs the hole, yes. A little different. The Cardial Seal is more of that cover. This is really the plug.
Okay. And instantly?
Instantly.
The tissue, the blood will stop circulating through?
Instantly. And what will happen is you can see again the Dacron insertion, the material in there will allow the blood cells to collect there and again form another skin over that.
Fascinating, fascinating. What's the incidence of this clotting?
Well, we do expect some clots on it. That's why we send people home on aspirin for 6 months. Once 6 months is rolled around, we know from all the years of doing this and all the previous studies that we've done that by that time the skin has grown over it and there's no risk of clot.
Fascinating. So this is a far less invasive procedure.
Oh, much less invasive.
What I can see.
And again, I think in terms of when we look at operative times and everything, the actual procedural time for this may only be 20 to 30 minutes. And the patients are breathing on their own. We don't stop the heart. It's really just a Band-Aid at the corner of the leg to recover. And typically within 72 hours, they're back to doing whatever they want to do.
How does the heart react when this foreign body invades it? And does it affect rhythm at all or anything? Can it like tickle the...
Yes, it can, because again, you are introducing something foreign into the heart, and this device, as in anything you put into the heart, has a stress point. The stress points on the Cardial Seal are where it folds in. The stress points of the Amplatzer are where the waste pushes out. These can irritate the wall of the heart, and they can cause some skipped beats. But we know that after time, those really tend to go away.
So the heart acclimates itself to this?
Yes, it does.
I see. It doesn't continue to become bothered and irritated by it?
No, sir. No,
wow,
sir.
That's very, 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 very fascinating, very interesting. What other defects can you treat through catheterization?
We can treat something called a patent ductus arteriosus.
Okay.
That's an abnormal blood vessel that connects between the heart, the aorta, and the lungs. It's another thing left over from birth. It's actually the 4th most common form of congenital heart disease, and those defects are treated with similar devices. We have an Amplatzer duct occluder device, and we also use sometimes just a little coil of this same nitinol material that's made up that supports that device can actually be placed as a coil and plug that blood vessel up. So that's really another big area that we've made a lot of inroads in. And those coils really began to be used for the patent ductus back in the late 80s. So that's an older procedure.
So you personally, you have done how many of these?
The ASDs and the AMP. Yeah. I personally have done over 800 of these.
800, wow. Yeah. Wow. What are the complications of this procedure other than tickling the heart inside?
Tickling the heart, we do watch patients for bleeding afterwards. We take a lot of care to make sure that the device, when we put it in, is sized properly. I think if you look at the real big complication, it's making sure that you size it. If you don't size it properly, then the device has nothing to grab onto, and the device can travel throughout the body. Now, I'm proud of the fact that in 800 cases, that's never happened to us. Okay. And I think we take a lot of care to size that. There's no mortality risk with this. Nobody's died from this procedure. But if you looked at one big thing, you would say that the tickling of the heart, we also treat with people with antibiotics to prevent the complication of infection as well.
In the future, after an individual has this done, is there a potential, like if someone with heart murmur problems gets subacute bacterial endocarditis, is there a higher incidence of this individual potentially coming down with this?
Yes, as long as we treat them with antibiotics, we prevent that.
So these individuals who have this procedure done, they've got to be told before you go to the dentist.
Yes.
You must always take your ADA, your American Heart Association's regimen.
Yes.
On antibiotics.
Yeah, we do that for anywhere from 6 months to a year, depending on.
Oh, what about the rest of their lives?
No, because once the skin has grown over it and the intra-device shunting is removed, then there's really no risk.
Oh, okay. That's really what my concern was about the future for individuals like this. So, again, what's the recovery period? What can people look forward to? If a child has it done, should he stay home for a week from school or what?
We generally look for a recovery. I always tell everybody 48 hours of downtime. Take it easy. Chill out, watch videos, do things, very low impact, low stress things. If it's the kids, I tell them not to wrestle with the siblings.
Right.
If it's the adults, I tell them no cleaning the gutters and no doing stuff like that. But after 48 hours, we let them return to their normal life. And then the people that really desire to do heavy athletic training, I tell them to wait 72 hours.
So this is good then for someone to get done on a Friday morning early and then take Friday, go home, Saturday stay in bed or relax, and Sunday do the same.
Yeah. Yes, sir.
And just stay on your antibiotics and stay on your aspirins, etc.
Yes, we put everybody that has a device closure like this on aspirin. We typically run them on aspirin for 6 months. In the children, we give them the baby aspirin, sometimes 3 times a week. All that does is it just prevents clumping of clots on these devices and allows for that time for that skin just to grow over that device and make it one with the heart.
Can you check to see the progress of what's going on with the closure through your ultrasound?
Yes, we typically see the patients back 1 month and 6 months. We do an extensive ultrasound evaluation of the device, make sure that we've got that it's closed, make sure there's no leaks, make sure that the skin has grown over it. Sometimes we even check and we even put an IV in and give some salt water bubbles to see if anything is crossing. And and it's been great. I'm happy to report that we've really had complete closure in over 99% of the patients we've done.
Wow, no kidding. That's terrific. What are the long-term issues with this now, like in 20 years, 30 years, 40 years that someone has it in?
I think that's going to be something we have to see and look ahead. Because the device has really only been used in this country for the last 8-9 years, and because Europe, we go back only 15 years, it's very difficult to predict long-term and say, hey, well, 30 years from now, where is that going to be? But these have been extensively tested, and I really believe that long-term there will be no issues with it. I think that once the skin grows over it, and we've seen this with the people that are now 8 years out, they don't even come and see us anymore because there's really no reason to.
My concern is that you have introduced metal, whether it's the Implantation or whether it's the Dacron?
The CardioSeal.
CardioSeal. Whichever one you use, there is metal in there.
Yeah.
And as that metal fixes itself against the wall, the heart's moving. And isn't there going to be an area of stress or erosion?
Well, it's interesting. It's interesting that you bring that up because with the CardioSeal, there's actually less metal, so that the erosion is much less. And because it's spring, the stress points are designed to give with the heartbeat. The CardioSeal doesn't really distort the anatomy. So in all of the cases, we've never seen an erosion risk in over 35,000 implants with the CardioSeal. The Implantation, the erosion risk comes when the implanter oversizes the device.
Okay.
So there is a real importance in the experience factor, having been there a lot, to be able to know what will provide too much stress and what will work and what won't. And there have been cases where they have reported inexperienced operators that have put in these massively big devices to close a smaller hole, that they've had late erosion, because that device will sit and press against the aorta.
Too close to tissue.
Yeah, mostly the aorta. It can lean on the back of the aorta.
Wow. Wow.
So it really it behooves anybody considering this to have an experienced operator in there.
What is, in general, what's the success rate of this procedure again?
I would say, I'm going to say over 99%, because we've never had a device that hasn't worked. In 800 cases,
wow.
We haven't had any embolizations. We haven't had any erosions. It's like anything out there. If you look nationally, those numbers are pretty well reproduced.
Are these procedures placed more in children or adults or?
The Implantation devices are more used in children because children present more with the holes, the ASDs. The cardial seals are much more used in the adults because they have the patent foraminal valley and have the stroke and migraine type symptoms.
I see. Okay, that's interesting. So the Implantation is more used more for children. Is there any special training? I mean, can some doctor just say, hey, hey, Implantation, send me 3 of them?
Well, generally what is involved is, for one, you have to be board certified in both pediatrics and pediatric cardiology.
I see.
Each of the companies have extensive training requirements before they let anybody be an independent operator. Mm-hmm. So they send out their panel of experts to watch you and observe you doing cases to make sure that you're going to represent their product very well. Both companies have a vested interest in not having anybody out there that's going to create complications.
Screw up.
Because all it takes is 1 or 2, and the FDA is going to pull everybody's.
Boom.
So they're very extensive. I had done about 300 cases before I even did my first one by myself with an experienced mentor on my shoulder. And those, in addition to the 800 I've done, put me over 1,000.
Yeah, well, that's very impressive. We have about a minute left or so. Any advice for people with atrial septal defects? Very quickly, give them a flow chart on what to do.
Basically, to look on, don't be afraid to go online to AGA Medical or NMT Medical. These are the companies that make these devices. They can tell you about them. Mm-hmm. There are many pediatric cardiology websites. The St. Francis Hospital website's a wonderful website. We'll also link to our practice website and give the patient information. There's also myheartdoctor.com, which is another great patient information site where they can read about this. Mm-hmm. And of course, contact a pediatric cardiologist and talk about it. The pediatric cardiologist will generally know much more than the adult cardiologist.
And also, if your child happens to have asthma, just get it checked out first and make sure it is not really one of these, an atrial septal defect.
Absolutely. Absolutely.
Yeah, that's very, very, very good advice. Terrific. Well, I got to tell you, Dr. Sean Levchuck, it has been absolutely terrific. The time went by just like that.
Sure did.
30 minutes went by in a flash. Great information, and I'm sure everybody watching is really impressed with this. I hope you got a lot of it, because I did. I learned from you today.
Thank
Terrific.
You,
Dr. Levchuck, will you come back again with more advances?
Yes, sir. Yes, Dr. Passes, absolutely.
A pleasure. Terrific. And I hope that you'll come back so you get a chance to learn more about the great things that's happening right here on our own Long Island. So, until we meet again, until next time, Dr. Harvey Passes telling you, whatever you do, just like Dr. Sean Levchuck, do it with passion and enjoy yourself. Until then, be healthy and happy.